Okay, well, we'll make a start, everyone. There's a few more people coming online now, but we'll start. So today I wanted to talk about burns in children. We don't talk too much about um, burns and so-called surgical problems, but burns are a really common problem in children, both relatively mild and severe burns, and um, and I think it's all pediatricians need to have a good understanding of burns and their effect on different aspects of physiology and how to manage these patients. So it can be something that's either very simple because it's a minor burn, or it can be much more complicated. So we'll go through that today. It's said that the burns are the most common mechanism of traumatic injury. So if you look at the list of traumas in children, both road trauma, accidents, drownings, and burns, it's said that in many low and middle income countries, the burns are the most common cause of traumatic injury and death in children under the age of 5. There's very limited data from Papua New Guinea since at least since 1996. There was some data around that time, but it's clear that burns are common and they cause a significant disability and they have a very high mortality. And the etiology is one could only speculate what the sort of etiology is around burns increasing or burns as a common aspect of community life for children. Firstly, open fires both inside and outside houses, the lack of parental supervision at times, and many young children, toddlers being looked after by older siblings, uh, a lack of enforced fire safety regulations, really, in countries that have controlled pediatric burns much better. They have had fairly strict fire safety regulations, especially around covering fires, protective barriers, clothing, etc. Um, there is some clothing that can more easily burn than others, and so cotton or woolen clothing is slow to burn, whereas nylon clothing um, burns very quickly. There were reports in the 1990s about high rates of burns among girls who are wearing grass skirts in the Highlands. They would catch fire when they stood close to a fire, but really very little in the modern era about the frequency of pediatric burns and the severity. And we know that across the world, where children with epilepsy are are at a much greater risk of having burns, just like they're at a much greater risk of drowning. Um, and especially where there's not well-controlled epilepsy, where medications are not as easily available, and many children have uncontrolled or poorly controlled seizures. So they're all some etiological aspects of burns, and I'm sure there's more. Just wanted to most of that's a bit of prevention and public health and that sort of thing, but I really wanted to go through a case to illustrate how we look after burns. And this was a child whose clothing did catch fire when he was standing outside his home near an open fire. This is a boy named Joshua. You can see him there. This is when shortly after he arrived at a referral hospital. Now he's at the time his father had taken off his clothes and they'd hosed him down with water as best as they could for quite some time. His parents then brought him to a health centre, and the nurse there irrigated his burns further, and then she applied saline-soaked gauze. You can see the gauze all wrapped around him, wrapped around the burns, and then she continued to irrigate that in the transportation by ambulance to the hospital, and she gave him some oxygen along the way. So the nurse did a very good job, I thought, in managing the first aid management of these burns, as did the parents, irrigating as much as possible. The burn can certainly prevent a deepening of the burn, but as it was, this boy had quite severe burns, which I'll describe shortly. He arrived 3 hours after the burn happened itself, or around about 3 hours. He'd been a previously well boy and he was fully immunized. And importantly, there was no explosion. This was an outside an outside burn. There was no a burn in an enclosed space. Of course, there was some smoke, but it's not. It's it has a different. The burn has a different quality to it when there's a explosion in a very confined space. So this was a flame burn occurring outside. When we should mentioned at the start, but burns patients are trauma patients, and we should go through an algorithm for trauma management whenever we see such a patient. They may, partly because they may also have other injuries, and partly because burns can affect multi-systems. It's not just the flame burn to the skin, but they can affect multi-systems, which we'll talk about. They may have other injuries because they've fallen in a fire, or they've had a fall, or they're running to get away from a burn. There's a variety of reasons why they may have other injuries. And the burns, as I said, can be a multi-system injury. There's the burn itself, there's the effect of the airway and the lungs, and then there's the effect of chemicals that are in the burn and in smoke. There's a lot of chemicals in smoke, which we'll talk about. Particularly cyanide and carbon monoxide, but there's other chemicals as well. But think about cyanide and carbon monoxide when you think about the toxicity of burns, especially from smoke. But burns result in a loss of skin integrity, and it leads to massive fluid loss, and it leads to heat loss. And many children with burns present to hospital hypothermic. Even though they've had a burn, they can be very hypothermic. They'll be losing heat very quickly from their broken skin. And it also obviously puts them at a third risk, which is exposure to bacteria or other pathogens in the environment. So three things: loss of fluid, loss of heat, and exposure to bacteria mean that the loss of skin integrity, that barrier protection we have on our skin, is very consequential for children with burns. And the greater the extent of the burn, the larger the body surface area, the percentage body surface area that's been burnt, that does relate to mortality. And it used to be that around about a 40% burn had a 40% mortality, etc. But these days, mortality from severe burns, which is probably more than about 25%, is less than what it used to be, because of a systematic approach to the management of burns, and a better understanding of how to manage burns. The stages of management of any sick child, including children who are injured or have had burns or drowning, are the same. And if we think about what to do at triage, how to provide emergency management, how to take a proper history and do an examination, and what you need for what aspects of history and what aspects of the examination you should be focusing on in something like a burn. Then laboratory investigations, if required, there will be some typically, and then the diagnosis is clear, but then looking for other injuries is very important, and providing treatment for the burn. That means both medical and surgical treatment, and providing supportive care, which is essential for both prevention of acute complications and the prevention of sort of more chronic, longer term complications. And then monitoring patients with burns is very important because they're at high risk. It's a very dynamic process whereby children can deteriorate quite rapidly because of large losses of fluid, because of hypothermia, because of infection, etc. And then discharge planning for children with burns often can be very prolonged, because they will often need multiple, if they've got a severe burn, they may need multiple surgeries, and they may need lots of physiotherapy and other things. So their discharge planning can be quite a prolonged process. There's a lot of working with families to go into as well. And then follow-up is important for all children with burns. So the point being that you need to think about all of these stages in any child who's had any serious illness, including burns. Now, we know that at triage we need to look for emergency signs, but there's a few emergency signs I wanted to particularly highlight in children with burns. Of course, you take a brief history, which we got from the father and the mother when they arrived, and of the injury, and then take the temperature, because that's important for all children, whether they've got a fever or whether they're hypothermic, and weigh the child, which is very important for the calculation of drug doses, and in burns, the calculation of the fluid requirements. We at triage, remember we've said that we need to pay attention to the airway, the breathing, and the circulation, and the level of consciousness. And there are some specific things that in burns you need to look for. Certainly, you look for stridor or obstructed breathing. And some children, if they've got facial swelling or they've got neck swelling or they've had a burn that affects their oral cavity, then they can have airway obstruction. Any burns affecting the face or causing swelling of the face or the neck, look in the mouth to see if a child's got soot in the mouth or they're on their lips. Sometimes they'll have soot on their lips or singed eyebrows or singed hair. That is these are risk factors for airway obstruction that might not occur straight away, but can progressively occur as the swelling increases. Sometimes the inhaling of hot smoke can lead to airway swelling, just like airway inflammation and swelling, and that can lead to airway obstruction. So the airways in pediatric burns is very important. If a child's got no features of airway obstruction and they've got no signs that put them at risk, then it's fine to leave them breathing spontaneously. If they've got severe already signs of airway obstruction, then they need emergency management. If they're somewhere in between, they need a lot of watching very closely. In terms of B, of course, you look for cyanosis and signs of respiratory distress. We do that in all patients, but particularly in burns, we need to think about not only we need to think about, have they had an inhalational injury? Have they inhaled smoke? Or is there some burn to if they've inhaled smoke, then often they'll have a burn to their oral or tracheal mucosa, and that can lead to further swelling as time goes on. It can lead to aspiration of the upper airway secretions, or the mucus that patients have got in their throat, especially if they've inhaled smoke. That I'll get onto that shortly. And then for circulation, as always, we feel the temperature of the hands and feet, feel the pulses for the pulse volume, and check the capillary refill time. But we also need to pay attention in terms of circulation. The biggest risk to the circulation immediately is fluid loss, and the extent of the burn influences the degree of fluid loss. So a child who's got more than 10% of their body surface area burnt, they need fluid resuscitation. And there are ways to calculate the body surface area burnt, which we'll talk about. Most of the this fluid loss occurs in the first 24 hours, although many children, if they've got severe burns, can leak for some days from their open burns. But most of it can occur in the first 24 hours, and children can go into shock quite quickly unless they get rapid fluid replacement. We need to take very close attention of a child's urine output, because that dictates the amount of fluid that they need and whether or not we're giving enough fluid. Sometimes children after 24 hours can get a hyperinflammation from burns, and they can get myocardial depression. But really the major cause of circulatory impairment in children with burns is fluid loss, and that's what we need to address to begin with. Many children with burns are quite lethargic or are in a coma if they've got a severe burn, and that can be because of shock, because of hypovolemia, or sometimes it can be because of other toxins in the smoke or in the burns. Certainly, carbon monoxide poisoning can lead to impaired conscious state, and cyanide poisoning can do the same again, which I'll explain shortly. So this boy Joshua at Triage you could see the burn on the side of his face, on his neck and back and buttocks. He fell backwards into his clothing got burnt when he was standing at the back of a fire, and then he fell over. He had quite severe burns posteriorly. His weight was 9.2 kilograms, and his temperature, he was cold, 35.3, but not as cold as I've seen some children with burns. You can see he had no stridor, even though he had facial swelling at the time. He had no stridor and no singed eyebrows or hair. So most of his burn was at the back, on his shoulders and arms, and back and buttocks from where the clothing caught fire. His respiratory rate was 45, and he did have chest indrawing, and his oxygen saturation, he arrived with on oxygen via an oxygen cylinder and that had come in the ambulance, and his oxygen saturation still was 92%. So still quite low for a child, which suggests that in the absence of airway obstruction, he's had some inhalation of smoke, which wouldn't be surprising. In this case, he had intercostal recession. His heart rate was 165, which could be because of hypovolemia, it could be because of pain, exposure, shock, etc. He had cold hands and feet and a thready radial pulse, and his blood pressure was 82 on 35, which is quite low for a child his age. His eyes were closed, but he moved when stimulated, so not very active. So an airway threat. He's got a breathing problem. He's got a circulatory problem, and he's got some impaired conscious state. As I said, severe respiratory distress, some signs of shock and reduced conscious state, but potential for airway obstruction because of his facial swelling, but no signs of airway obstruction at the time. If a child's got any signs of obstructed breathing when they present, then that you can't relieve completely by pulling their jaw forward, just a bit of jaw thrust, then they need to be assessed for intubation early. Because if they've got, when they present, if they've got some signs of airway obstruction, then it's likely it's going to get worse in the coming hours. This boy Joshua didn't have any signs of airway obstruction, although he had severe respiratory distress that was probably related to inhalation of smoke rather than airway burns. So he got lots of oxygen for reasons I'll explain later. There can be other reasons why early intubation of patients is sensible. One, if they need surgery, then they're going to be intubated. Two, if they need an echotomy because they've got circumferential burns or they've got a potential compartment syndrome, they'll need an anaesthetic and therefore they need to be intubated. For some children with burns, their analgesic requirements are very high in the early stages, and that can cause them to hypoventilate, and then they may need intubation. Some children, like Joshua, can have a poor conscious state and are at risk of aspiration pneumonia. I think the aspiration pneumonia that children with burns get, it's especially the case in children with severe burns who need to be intubated or ventilated for a period of time. But it occurs in other children as well, especially if they've been poorly conscious at the scene or become unconscious when at the time of the burn and then been roused to consciousness. And I think that's because they get a lot of mucosal inflammation and mucus production, and they've got bugs in the back of their throat, which most children have, often streptococcus or staphylococcus or haemophilus, just a sort of normal airway bugs. And they can be, when children cough and splutter and they get smoke into their lungs, then they usually get those bugs in their lungs. And so many children with severe burns that affect their lungs or their airway will end up with an aspiration pneumonia in the coming sort of 3 to 5 days. There are some children that when they inhale smoke, they can get carbon monoxide poisoning because carbon monoxide is a component of smoke. And not in this case of the case I'm talking about, but if there is plastic involved, so if a burn, a fire happens in an enclosed space, especially where there's plastic furniture or other forms of plastic, and there's chemicals released from the plastic when the plastic burns rapidly, then that can release cyanide, and cyanide poisoning can be a big problem for children with burns, especially when there's an explosion in an enclosed space. So those two things, carbon monoxide and cyanide poisoning, or just airway mucosal burns from aspiration. Often this inflammation of the lung progresses over the first 3 to 5 days in children who've had that sort of burn. And then sometimes if a child's got a severe burn, because of the mucosal burns or a capillary leak syndrome that occurs after a few days, or early actually, and continues for quite some time, they can get a degree of pulmonary edema. And so all of these things can lead to inhalational injury in children with burns. And usually, if a child does need intubation and they need intubation longer than about a week, then we'll do a tracheostomy because it makes their management so much better, so much easier, and it's more comfortable for the child. But that's only if they do need intubation to begin with, or at some stage. Emergency treatment for this child, give lots of oxygen for reasons I mentioned. Um, get an intravenous line in. The child didn't came without an intravenous line but needed a IV line. He had signs of shock when he presented, so give a bolus of fluid and then start the fluid replacement, the standard fluid replacement for burns immediately, and catch up a bit on what on the hours that have gone. This boy arrived 3 hours after his burn, so therefore he'll have had 3 hours of fluid loss, and that needs to be caught up. Um, Glucose is important. If patients, all children need a source of glucose, and any child who's got a severe injury like this will need to have their glucose checked. Giving analgesia is important, so you can give zero point 0.1 milligrams per kilogram of morphine every 2 to 4 hours, or you can give a continuous infusion of morphine. There, continuous infusion of morphine probably is better, but often these children need boluses of morphine. Don't be scared about giving morphine to such patients, or indeed ketamine. And there are many patients with burns that can be on an infusion of morphine and some ketamine, and they can breathe quite fine even without ventilatory support, although some do need that if their analgesic requirements are very high. Pass a nasogastric tube, because most of these burns patients will have gastric stasis and they risk vomiting and aspirating, and put in a urinary catheter. It's essential for the monitoring of urine output, which is essential for the monitoring of the adequacy of the fluid replacement that we give. Now, in terms of the assessment of a burn itself, there's two things we need to know. Firstly, how deep is the burn? And secondly, how much of the body surface is burnt. Then there's good mechanisms for understanding each of those things. There's 3 degrees of burn, partial, um, more intermediate, and then full thickness, or sometimes first, second, and third degree burns. And if you think about it as first degree burns, are just like sunburn, a bad sunburn where the skin isn't breached. These burns are quite red or pink, and they may blister a bit like sunburn can, but the skin isn't breached. There's no necrosis of the skin as such, just the top layer is breached. And then full thickness burns, they're usually either charred or they're white. And they're usually dry. They're not usually weeping like partial thickness burns, and they are anesthetic. They have no feeling, and they don't blanch on pressure because there's very little blood supply to a full thickness burn. I'll show you some illustrations that can help with that. The second thing is we need to decide how much of the body surface area is burnt. And there are good charts for this. You probably understand about the rule of nines that we can use, which I'll explain. There's a good chart in Hospital Care for Children on page 270 that describes the rule of nines as it applies to small children. Um, you can use other ways to estimate a child's percentage body surface area burnt, but I think the best way I'll explain shortly. This is um, Joshua's burn, and this is a superficial burn. This is like a first or maybe mild second degree burn. You can see it's red compared with Joshua's burn that was quite white, and where there's evidence of tissue necrosis. Making a distinction is important between first and second and third degree burns. Often, sometimes early on, you can't quite tell exactly what it is, and it takes a day or so for the burn to be very clear. But it is important because first degree burns are like sunburn, and they will heal or re-epithelialize. The epithelium grows again within 2 weeks. A second degree burn that's more, which is a bit deep, it's intermediate thickness. They will re-epithelialize, but they often re-epithelialize with scarring as well. But they will clear. And then a third degree burn that just won't, like some of those burns that I showed you before, they will not re-epithelialize and they need skin grafting. So making the distinction is important because it tells you which burns will get better spontaneously and which burns require some intervention. So the depth of the burn is important. The, there are different sorts of burns, and I don't want to go into this too much. We're talking mostly about flame burns today, but there are some children that get burnt by chemical burns. And so, chemical burns like household cleaning agents and either alkalines or acid. So, hydrochloric acid or alkaline like ammonium chloride that is often a household cleaning product. Those chemicals generally don't cause extensive burns, not large body surface area burns, but they can cause quite severe burns, chemical burns, and it depends on the duration of contact, the strength of the chemical, and the solubility, just how much it will penetrate through the skin and into tissues. But chemical burns is another sort of burn. We mostly think of burns as being flame burns from fire, but there are chemical burns. There are also electrical burns. Now, these are rarer, but they occur usually from um, electrocution or they can occur from lightning. And when a child has an electrical burn, there's almost always an entry wound and there's an exit wound. And along the path, the arc between the entry and exit wound, there will be burns. The tissue will be burnt. It's often quite hard to tell to begin with just how extensive the internal burn is, the deep thermal burn is from looking at the patient. They may have a seemingly a milder burn on their hand where they've grabbed some electrical equipment, and they may have an exit wound on their foot or something, but it's the internal burns that are most consequential. And for children who've had electrical burns, then I won't go through this in too much detail today, but all the tissues in that path, whether it's muscle necrosis or whether it's the burn, the arc of the burn has gone through the heart muscle leading to an arrhythmia, or whether it's even affected the spinal cord. These are all things that when you have an electrical burn, you need to think about. And so sometimes, even with a relatively minor superficial burn, a child with an electrical burn can have quite some severe consequences. And so all children who've had an electrical burn need close monitoring. Even if their superficial burn is not that severe, they need close monitoring for 24 hours at least to make sure they're not going to get other consequences of the internal burn. But we'll get back to flame burns, I think, because that's what we're mostly talking about. And I just wanted to we've talked about the depth of the burn, but any burn, especially a deep burn, has a number of different zones around where the burn is really caused the most tissue necrosis. The burn is causing the tissue death of the epithelium and the deeper layers. Then that will often that's necrotic tissue that will be irreversibly damaged by the burn. That again needs grafting. But there's always a zone around that burn where there's some tissue inflammation or damage, but there's some and burn, but there's some viable tissue, and that viable tissue can regrow. And this is important because this is why we want to maintain good oxygen levels and good blood flow and good hydration to such patients. Because if you do provide that, then that area, that zone of stasis where there's some viable tissue and some burnt tissue will heal quite well. But if a child's in shock or they're hypoxic, then that area around the zone of stasis, it's called, won't heal as well. And then around that, there's a zone of hyperemia or a zone of inflammation where you often get, it looks like the burn might be a bit infected because you get a red zone of inflammation around it. That's just increased blood flow and local inflammation. Polymorphs and other white cells are attracted to the burn. So think about burns in that way, but especially that zone of stasis in the middle where we can protect that area from getting more and more burns. It's a bit like in the early stages of burns. Burns don't happen even if you get a flame burn or a scald, it doesn't happen all at once. For the next hour or so, a patient can still be the tissue can still be burning, and that's why intense deep irrigation. The longer you can irrigate a burn, if a child can stand under a cold shower for half an hour or even an hour and just irrigate the burn as much as they can, then that's probably the best thing that can happen. And I've had many children whose I think burns have been much improved by their parents having the understanding that if a child has a burn, then they have stood under as cold a shower as they can get for an hour, and that's probably more important than any sort of medical therapy that can actually be done later in the hospital. Okay. When you're assessing the extent, the total body surface area burnt, remember there's this rule of nines, and it's a little bit different for children. This is from the hospital care for children, and there are two differences I think between children and adults in terms of body surface area and body parts. And one is that children have a relatively larger head, and two, they have a shorter legs. The rest of it's about the same in terms of proportions, but when this child, when Joshua's um, percentage body surface area was assessed, he had a total surface area burn of 36%, which is a large burn. Most of it was on his back, but you can see the back contains a large proportion. The back is 13%. The back of his head was 9. Upper thighs and upper arms, it adds up quite quickly. Even though his front and his face weren't burned at all, his back was burned quite substantially. As I said, the difference between children and adults, largely children have a relatively larger head, and they have shorter legs. Uh, you can make an assessment of um, a a child's percentage body surface area burnt by thinking that the child's palm is 1%, and therefore you can make an assessment based on that. But I think using the rule of nines is quite important, and knowing when a child transitions from being a toddler or a young child, even a school-age child, to being an adolescent is important. And then you use the adult chart. This child I was talking about had 36% total body surface area burnt, and the fluid replacement he needed was mostly crystalloid solutions. We used to give some of the fluid replacement as albumin if you have it, but that's rarely available. So it's okay to give crystalloid solutions. So balanced crystalloids is the most useful. If you've got Hartmann's solution or Ringer's lactate, another name for that, with some glucose, or if you don't have that, then normal saline with 5% glucose, or even if you have it, half normal saline with 5% glucose. And you need to calculate half of the replacement for that 36% burns is given in the first 8 hours, and the other half in the remaining 16 hours. And there's a way to calculate the amount of fluid. It's called the Parkland's formula. Many of you will have heard about it, and it's based on an estimate of the percentage body surface area burnt. And the Parkland's formula says that we give 4 mils per kilo per percentage body surface area burnt, plus that child needs their maintenance fluid. So this is 4 mils per kilo. He was 9.2 kilos times 36 being the percentage body surface area burnt, and that comes to 1,325 mils. So over a litre of fluid, 1.3 litres of fluid the child needs in the first 24 hours. And half of that should be given in the first 8 hours. So half of 1,325 is 662. And if you divide that by 8, because you're going to give that in the first 8 hours, then you get 83 mils an hour for the first 8 hours. But remember, he's got to have his maintenance fluid on top of that, and that is 100 mils per kilo for 24 hours. So that's 920 mils, and divide that by 24, that's 38 mils an hour. So if you add up both um, 83 plus 38, you get to about 120 mils per hour for the first 8 hours. And then in the next 16 hours, he needs 80 mils an hour. And that's work that out by the extra 662 mils he needs, divide that by 16, and then add the 38 mils an hour on top of that. Takes a bit of working out, but it's possible to work it out based on the Parkland's formula, giving half in the first 8 hours, the rest in the next 16 hours. So this boy needed 120 mils an hour for the first 8 hours and then 80 mils an hour for the next 16 hours. And of course, that's just a start. You need to then come back and assess the patient and see whether his urine output is adequate. And that will tell you whether or not you're giving enough fluid. The earliest thing that goes off when you're not giving enough fluid is the urine output trails off. It's less than 1 mil per kilo per hour. We should be aiming for at least 1 mil per kilo per hour of urine output in a patient who's had burn. That tells you that you're giving probably enough fluid. You never try to achieve that with frusemide in a burns patient or Lasix in a burns patient. You're not trying to achieve a urine output like that. You're only trying to achieve a urine output by giving the right amount of fluid. If they haven't got a good urine output, it's because you're not giving enough fluid usually. Pain control is very important in patients with burns, and you can. I always give multimodal pain analgesia in such patients. Paracetamol to start with. Um, Most patients can tolerate paracetamol through the nasogastric tube, and morphine. I mentioned it can be given as zero point 0.1 mils per zero point 0.1 milligrams per kilogram every 2 to 4 hours, or as a continuous infusion, which is 10 to 30 micrograms per kilogram per hour, depending on the severity of the burn and the age of the child. But that's many children have up to that much and can still be awake and breathing spontaneously. I won't talk about how to make that up today, but you can make up a continuous infusion of morphine and run that if you've got a syringe driver and run that safely, or give zero point 0.1 milligrams per kilogram of morphine every uh, every 2 to 4 hours, and give it regularly. Don't wait for the child to have pain. Point one is fine. Yeah, and often in most patients with burns, I think both morphine, paracetamol, and ketamine can be very useful. And running some ketamine in such patients is very useful. It can really help with analgesia as a continuous infusion. We use a lot of ketamine for dressing changes and things, but also running a low level background analgesic rate of ketamine infusion can be very helpful. Um, Not all patients, but many burns patients need one of two lots of surgical treatment, either debridement of dead skin if they've got severe burns. This is surgical management, which we don't need to know too much about, but they need that can be the best way to prevent infections in patients through removal of dead skin. And if they've got a compartment syndrome like circumferential burns, they need an eschorotomy, which just means releasing the stricture of the burnt tissue from viable skin and tissues, and ensuring that there's adequate blood supply more distally to the wounds. Again, burns it's a multidisciplinary approach. You need good emergency care and good surgical care and ongoing care from paediatricians. Infections are important in burns patients, and our biggest obligation is to try to prevent infections in such patients. And so if it's a mild or moderate burn and the skin is intact, then you should clean the skin with antiseptic solution. Usually we'd use chlorhexidine. Sometimes that can give a bit of a rash, but it's usually the best way to do it. If the skin is not intact, then the burn needs to be debrided. So either cleaned fairly vigorously so that all the dead tissue is removed. That will help to prevent infection. It's really in dead tissue that infection takes over. You should clean and dress the wound daily unless the burn is small, but usually cleaning it daily, and that can be either covered in gauze or it can be managed by leaving it open to air. there is a there is still a role for topical antiseptics in some burns. SSD cream that we used to use a lot of, it's less used now than previously, and usually for deeper burns only, so third degree burns. There are other antiseptics you can use for third degree burns, chlorhexidine being one of them. Some people use even honey to as an antiseptic. It's an anti-staph agent, but SSD cream and chlorhexidine are good um, antiseptics. They're not antibiotics; they're antiseptics for burns. But again, for more severe burns, hand hygiene is essentially is essential for the management of patients with burns, because what we don't want to do is transfer any other serious bacteria to their burns. The role of antibiotics is important too, and of course, if infections are present, then well, firstly, the most important way to manage infections is debridement of tissue, so cleaning a burn. Antiseptic is more important than antibiotics, generally speaking. There is a limited role for prophylactic antibiotics. I think only if you've got a dirty wound or the child's been um, taken a long time to get to hospital, if when they present their burns appear infected. The most important thing for those patients is debridement. But uh, certainly at the time, there's a risk of bacteremia in the first 24 hours. So giving, if you've got a child who's got dirty burns, then or potentially infected burns, then 24 hours up to 48 hours of antibiotics to start with um, can reduce the risk of bacteremia, especially when they're going to the operating theatre and having debridement, because that can lead to some bacteremia. Beyond 48 hours, I wouldn't treat with antibiotics unless the patient had ongoing infection or you proved a bacteremia. Sometimes during repeated debridements, if the patient's got um, evidence of infection, then they may get a bacteremia during the scrubbing of the burn and debridement. And then it's really important that if you're going to give antibiotics, then give a dose of antibiotics an hour before the child has the debridement of their wounds or the cleaning of their wounds. Very important to give it an hour before, so that when that debridement happens and the bacteremia potentially occurs, then they have antibiotic levels that are up to a treatment level at the time that the bacteremia might occur, to prevent that becoming more widespread. So I think a very limited role for prophylactic antibiotics. So what I don't like to see is patients that are put on antibiotics at the start and they're left on antibiotics for a week or two, and they will all get multi-resistant organisms, and they may just get colonized with multi-resistant organisms, but eventually, if they get an infection in their wounds, in the burns themselves, then they'll get multi-resistant organisms in the wounds, and that becomes very hard to treat if a child's got Pseudomonas or some other hospital-acquired infection on the wounds. You should check the tetanus status and give tetanus immunoglobulin or a tetanus toxoid or both. I think most children should have um, certainly tetanus booster and often tetanus immunoglobulin. I've talked a bit about the cause of lung disease in burns. I won't talk too much more about this, but it's very common for children who've had quite severe burns to get an aspiration of the organisms, the bacteria that are in their throat, because of the mucosal inflammation, and they're producing lots of mucus, and they cough and splutter, and they get some smoke or other mucus down into the lungs, and then that can set up an infection. So maybe up to more than half of all children who have severe burns get a secondary pneumonia, and you need to be aware of that and treat with antibiotics. Sometimes it's not infection, but just a progression of some chemical inflammation in the lungs. Very hard to make a distinction, but there's many reasons why children with burns can get um, a chemical pneumonitis, not infection, not a pneumonia, but chemical pneumonitis. And I mentioned pulmonary edema. I also mentioned carbon monoxide poisoning, and we treat that, if a child's had smoke inhalation, we treat that with 100% oxygen, even if their saturation is okay, then it's still good if they've got carbon monoxide poisoning or potential for carbon monoxide poisoning to give them 100% oxygen for a period of time. And and as I mentioned before, the the circumstances under which you should consider cyanide poisoning, and that's especially if there's an explosion and especially if the plastics are involved. Cyanide poisoning leads to an unexplained metabolic acidosis. There's plenty of other reasons why a child with burns could have acidosis, like hypovolemia or infection. Um, but if they've got an unexplained metabolic acidosis, then think about cyanide poisoning because cyanide, of course, causes mitochondrial toxicity. It blocks the uptake of oxygen by mitochondria, and so therefore cells can't use oxygen, and then they go into anaerobic metabolism and they produce lactic acid. That's the origin of the metabolic acidosis in cyanide poisoning. These patients need treatment for with oxygen, but I also need treatment with hydroxycobalamin. It's vitamin B12. It's a that if you treat them with hydroxycobalamin, then that's a cofactor that can help overcome the cyanide poisoning. And yeah, just important to think about all patients who've had, been in an explosive um, had an explosive burn or where there's been burnt plastics, then I usually treat with vitamin B12. Nutrition is very important in burns patients and often forgotten because we're thinking about the intravenous fluids they need. But you should start nasogastric feeding as soon as possible in the first 24 hours. The earlier you start, the better, because it reduces the risk of uh, mucosal injury to the gastrointestinal tract and then bacterial translocation across the gastrointestinal tract into the bloodstream. It reduces the risk of bacteremia if you start feeding these patients. And they go into a hypermetabolic state, many such patients, and they need sort of a high calorie diet with adequate protein and vitamins. And so ideally, you start them on F100 because that's a balanced nutritional supplementation. So if I had a burns patient, then I usually put them on an equivalent of an F100 formula. They often need, because of in the first week or so, they often have a hypermetabolic state, and you to keep pace with their energy requirements, they often need 1.5 to even 2 or 3 times well, 1.5 times the calorie requirements and an increased protein requirement as well, sometimes 2 times double the normal protein requirements because of this hypermetabolism that children with, large burns go through. In other aspects of supportive care, physiotherapy is very important to prevent contractures. And many children that have limb burns, flexural burns, they will heal somewhat by contractures and early physiotherapy, mobilization of limbs, and splinting of limbs to prevent contractures is quite important. And these patients often need quite prolonged physiotherapy to get the best use of their limbs that they can. All patients, as I said, need monitoring. We talked about supportive care and monitoring. They need standard monitoring using a, a, a ideally a pediatric monitoring and response chart. You look especially at their airway, breathing, circulation throughout, monitor the adequacy of their circulation. Not because remember, whatever their circulation is at the time, it might be quite different to what it looks like in 8 hours' time or 24 hours' time when they might have lost a lot more fluid. And and you can assess using a monitoring chart like this whether the child's pain-free or not, you can do a pain score on them and assess whether or not you're giving adequate analgesia. And you can also monitor their nutritional intake and record all of that. I think such charts are very important for such children with multi-system injury. There are a couple of other considerations, I think, in terms of burns. We're almost finished, but um, I mentioned before the hypermetabolic state of burns, and there is some evidence that using propranolol, a beta blocker, can reduce this hypermetabolic state and enable the energy that you're providing to be used for wound healing. And for some children that have a marked tachycardia or this evidence of a hypermetabolic state, then it can be useful to have them on propranolol. Um, um, yeah. Many cases of burns, we need to also think about whether there are any child protection issues, and not for all burns, but for some burns, children who are caught in fires, there's issues of neglect, and that needs to be addressed by um, social work support, both to address that issue and to support the family, because these families need a lot of support. They need a lot of help if their child's going to recover and rehabilitate from burns. And they clearly need long-term physiotherapy and rehabilitation and to get back to school. They're often quite mentally scarred as well, and so they need a lot of multidisciplinary input to have the best possible rehabilitation that they can. All right, I'm going to stop there. We've gone through pediatric burns, especially the management, the multidisciplinary and multi-system approach to management. And I'm going to stop there, and I'm happy to answer any questions that you might have.